Hi friends, I am Dr. Biswajit Banerjee. I practice diabetology in Kolkata. Today we will discuss how to manage a newly diagnosed type 2 diabetes patient with high baseline HbA1c level. Our patient Mr. AB is a 45-year-old person with newly diagnosed type 2 diabetes, and he visited my clinic 6 months back with multiple risk factors like obesity, hypertension, and hyperlipidemia. This type of patients we see day in and day out in our clinical practice. As per all international guidelines, he was initiated with metformin with advice for lifestyle and diet modification. Now, recently he visited again as part of routine checkup. His laboratory workup shows following reports. HbA1c was 8.5%, eGFR is 80 milliliter per minute per 1.73 meters square, LDL value is 80 milligram per deciliter, HDL is 38 milligram per deciliter, and triglyceride was 200 milligram per deciliter. Presently, the patient was on metformin 1000 milligram BD, lisinopril 40 milligram once a day, metoprolol extended release 100 milligram for hypertension, atorvastatin 40 milligram once daily for dyslipidemia, and aspirin 75 milligram once a day. His physical examination reveals he is a borderline case of obesity with BMI 31 kg per meter square. With these antihypertensive medications, his blood pressure is controlled. His present blood pressure is 120 by 70 millimeter of mercury. And as the patient is on beta blocker like metoprolol, his heart rate is very important. In this case, his heart rate is 78 beats per minute. Now the question comes, with a newly diagnosed diabetic patient with a very high HbA1c, what should be the line of treatment? There are two types of therapy in clinical practice in diabetes. One is treat to failure, and one is very proactive approach. What is treat to failure? You start with one drug, go up to the highest dose of that drug. When there is blood sugar is not controlled, then add another drug. But in the proactive approach, we start with multiple drugs, 2 drugs or 3 drugs from very beginning. Evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of microvascular and macrovascular complications in type 2 diabetes as per UKPDS. UKPDS data demonstrated a legacy effect of early intensive therapy because the difference in the cardiovascular event rate 10 years post-trial was lesser in case of in the patients who were very proactively managed and their blood sugar level was cut down to near normal from the very outset of the diagnosis or outset of the disease. Even though there is another finding, no difference in HbA1c levels between the intensive and conventional therapy was noted, still the CV event 10 years post-trial was much more in the controlled group. Now, when metformin is not suitable, and empagliflozin or linagliptin is being considered as an alternative first-line treatment. We can initially combine this therapy to control blood sugar very fast to achieve target more quickly, particularly in patients with high baseline HbA1c level. Early combination therapy in type 2 diabetes makes clinical sense for several reasons. What are the reasons? First, a meta-analysis demonstrated that early use of combination therapy significantly increases the likelihood of achieving the glycemic target of HbA1c less than 7% compared with metformin monotherapy. For patients with HbA1c more than 1.5% above the goal at diagnosis, ADA and EASD guidelines recommend first-line treatment with a dual combination and an SGLT2 inhibitor as the first post-metformin treatment in patients with established cardiovascular disease or a history of CHF or CKD. IMPA and LINA combination with complementary mechanism and pleiotropic benefits may be a suitable option across a range of patients, including those with established atherosclerotic cardiovascular disease or high risk, established heart failure or CKD, and both these drugs are, there is no tolerability issue either in combination or if we use any of these drugs as a single agent. But they give potential benefit as far as cardiovascular and renal outcomes is concerned. There is no increased risk of heart failure with either agent, so this is cardio safe. And now we know that IMPA and LINA are both are safe as far as renal disease is concerned. According to a study, early achievement of HbA1c goal, that is less than 7%, with IMPA-LINA could reach target HbA1c at 12 weeks compared to monotherapies. So we should start with a combination therapy with a goal to reduce the cardiovascular mortality and to protect kidney right from the beginning if the HbA1c is more than 1.5% of the upper limit. In our case, the blood sugar was more than 1.5% of the upper limit, that is 7%. The patient's HbA1c, entry HbA1c, was more than 8.5%. HbA1c decrements by IMPA-LINA, that the dose is 25 by 5 milligram, has demonstrated 1.81% HbA1c reduction at HbA1c baseline, more than 8.5% at 24 weeks in metformin treated groups. The benefits on glycemic control were maintained at week 52. That is, a year-long glycemic control benefits are maintained in metformin treated groups, and a higher percentage of patients achieving HbA1c less than 7% were reported for combinations. So combinations are more effective than metformin monotherapy groups. The combination offers a suitable component in strategy to achieve target HbA1c without increased risk of hypoglycemia and weight gain, with improvement in overall lipid profile. These are the pleiotropic benefits. Overall lipid profile is increased. In our case, triglyceride is 200 milligram percent, and there was loss of weight. A reduction in the incidence of genital infections associated with SGLT2 inhibitor has been reported when a DPP4 inhibitor is added. Now the question comes, why the incidence of genital infections are lesser in SGLT2 inhibitor and DPP4 inhibitor combination? There may be two causes. One cause is maybe in case of fungi, they also have DPP4 enzymes in their body. When we inhibit DPP4, the fungus DPP4 also is inhibited and they got inactivated. And second cause, that because of a better glucose control, although other possible, the second cause may be the better control, glucose control, but other possible mechanisms remains to be investigated. In summary, IMPA-LINA combination provides robust HbA1c reduction and 2 to 4 times higher odds of patients reaching the goal HbA1c compared to individual agents with low hypoglycemic risk. So, young patients, entry HbA1c very high, we should start with dual therapy, and the ideal dual therapy will be an SGLT2 inhibitor and DPP4 inhibitor. Namely, we can use a combination, fixed dose combination of empagliflozin and linagliptin. Thank you for your patient hearing.